We've already covered the structure of the heart and the anatomy of the heart, so now we're going to take a look at heart physiology and how the heart is actually able to work to pump blood. So in order to do that, the heart has to contract for our blood to be able to move through our body. When the heart contracts, blood is going to take its continuous round trip into and out of the heart through the rest of the body and then back to the heart again. In one single day, the heart pumps about 6,000 quarts of blood. Now, that's not how much blood we actually have in our body, but that is the volume that is pumped by our heart throughout the day. And how does this actually happen? We're going to take a look here. So there's something called the intrinsic conduction system of the heart, and that's going to be what sets the basic rhythm of the heart for us. The atria and ventricles are going to contract independently of one another. Atrial cells beat about 60 times per minute, and ventricular cells beat about 20 to 40 times per minute. Okay. There are two systems that will work to regulate that activity of the heart. The autonomic nervous system will work to either increase or decrease our heart rate, depending on conditions, both internal and external, that we're dealing with. And then we have the intrinsic conduction system of the heart, which is referred to as the nodal system. So you can see in the picture here, we have the sinoatrial node and the atrioventricular node. That system is built into the heart tissue itself, and that's going to be what sets the basic rhythm of our heart. There is special tissue that makes up this intrinsic conduction system, or again, the nodal system, and we have that tissue nowhere else in our body. It's similar to if we could make a cross between muscle tissue and nervous tissue. That is kind of what this tissue would be similar to. What it does is cause depolarization from the atria down to the ventricles. And it's going to enforce a contraction rate of roughly 75 beats per minute. And it works to keep the heart beating as one coordinated unit, even though the atria and ventricles will be beating separately from one another. So we have the SA node, or the sinoatrial node. It's a small mass of cells that we have in the upper right atrium. It's the most important part of the intrinsic conduction system. It's got the highest rate of depolarization of the whole system, so it pretty much sets the pace for the entire heart, and we refer to it as the pacemaker of the heart. So that will receive a signal, okay, from our nervous system, but that impulse will spread from the SA node through the atria, and then it's slightly delayed so that the atria can contract before that signal will continue onto the AV node so that the ventricles can follow. The AV node would get the signal next. It's going to be essentially the second part of the intrinsic conduction system or nodal system. It's where the atria and ventricles would kind of join on the right side. You can see it right here. And that is going to be the AV node is what electrically connects the atria and ventricles together. It's going to receive signals from the SA node, and then that signal, that impulse, will spread through the AV bundle, okay, which is also referred to as the bundle of His. We see that right here, okay, kind of in between the two ventricles. Then it will go through the bundle branches, which we have here, kind of in the interventricular septum there, and then through the Purkinje fibers, and we have those around, kind of on the outsides of the ventricles. Okay, so the signal would start here overall, then be sent to, or at the SA node, then would be sent to the AV node, and then through all of these fibers. We think of kind of like if you turn on a light and there's a slight delay before the light actually switches on, that's going to be kind of like the flipping on of the light switch would be like the SA node getting its signal, and sending the signal to the AV node and then spreading through the ventricles before, like in that situation, the light would come on. There are some imbalances that can happen with that conduction system. The first is called a heart block. When this happens, the ventricles are no longer electrically connected to the atria, and they beat independently of the atria and at a slower pace. So a treatment for that would be to have an artificial pacemaker implanted that would regulate that person's heartbeat. Next, we can have ischemia, and that is a lack of blood supply, of adequate blood supply to the heart muscle, and that can lead to fibrillation. Fibrillation is a rapid and uncoordinated shuttering of the heart muscle, so it pretty much makes the heart kind of useless as a pump. This is going to be a major cause of death from a heart attack in adults. If you are in fibrillation, you can be in AFib or atrial fibrillation. This can happen in where the atria, in that case, aren't pumping efficiently. They're not pumping blood down into the ventricles. AFib is actually the number one cause of strokes because blood's building up in the heart and not being pumped out like it should. So you can develop blood clots in the heart, and then that can lead to a stroke. A treatment for fibrillation is a defibrillator used to restart the electrical conduction in the heart. So if, like with that, they would use like the paddles, you see it on TV or in movies, I'm sure, where like they shout clear and then they shock the person with paddles. That is to kind of electrically restart their heart. Some other problems would be an arrhythmia, that is an irregular heart rhythm. Next is tachycardia or tachycardia, that's a fast or rapid heartbeat. Prolonged tachycardia can progress on to fibrillation. And then bradycardia is slower than normal, which if it's too much, like in this case, it would be below 60 beats per minute. That can cause issues because the blood's not being pumped to your body the way it should be. For cardiac cycle, in a healthy person's heart, the atria will contract simultaneously, so meaning the right and left atrium will contract at the same time. And as they start to relax, then the ventricles start to contract. Okay. So there's systole, which is contraction of the heart, and diastole, which is relaxation of the heart. So kind of think how, got a typo there, let me fix that. Think of how that relates to blood pressure. So you have your systolic blood pressure and your diastolic blood pressure. Okay. Contraction almost always refers to the ventricle, since that's the main part of the pump of the heart. And the cardiac cycle is referring to the events of one complete heartbeat during which the atria and ventricles contract and then relax. The average heart beats approximately 75 times per minute. So the length of a cardiac cycle is roughly 0.8 seconds. Okay. And there's 3 periods in a cardiac cycle. So the first period is mid to late diastole. That begins when the heart is completely relaxed. Pressure in the heart would be low, and blood is flowing kind of passively into and through the atria and down into the ventricles. The semilunar valves are closed, so the pulmonary and aortic valves would be closed. The AV valves, tricuspid and bicuspid valves would be open, and the atria contract and force blood down into the ventricles. The second period is called the ventricular systole. Right after ventricular contraction starts, pressure in the ventricles is going to increase. When that happens, that forces the AV valves shut. Semilunar valves are forced open at that point by the increased pressure because the ventricles are contracting, and blood is going to go from the ventricles through those through the semilunar valves into the arteries, so into the pulmonary trunk and then the pulmonary arteries or into the aorta. And the atria would be relaxed at this time and be refilling with blood. Then the third period is called early diastole. That's when the pressure inside the ventricles drop. The AV valves will open, the ventricles will refill with blood, and then that completes the cycle. So in a person's heart who is working properly, their heart's working properly, All of that would take about 0.8 seconds. Okay, so here we can see these three phases. So the ventricles are filling and the atria are contracting to push that blood from the atria down into the ventricles through the tricuspid and bicuspid valve. In ventricular systole, the ventricles are contracting. That forces the tricuspid and bicuspid valves shut. The blood would be leaving through the pulmonary or aortic semilunar valves. And then early diastole is when the atria are refilling with blood before they contract and push the blood into the ventricles. For heart sounds, there's two distinct sounds that we hear when we listen to a person's heart during a cardiac cycle, and we just call those heart sounds. It's kind of a lubbed up sound. The lub part we hear, which is caused by the AV valves closing, it's the longer and louder part of a heartbeat that we hear. And then the dup is caused by the closing of the semilunar valves or the pulmonary valve and aortic valve. So it should be lubbed up and then kind of a pause, lubbed up, pause, and so on. Again, a person with a heart murmur, their heart sounds would sound like lubbed up whoosh, because that whoosh is the blood rushing backwards because the valve isn't closing properly. So you hear that backflow of blood. You can actually hear that when somebody has a murmur. So we're just going to watch this video quickly, or part of it at least, so you can see or hear, I should say.
When a healthy heart beats, it makes a lub-dub sound.
Heart murmurs.
The first heart sound, lub, also known as S1, is caused by the closing of the AV valves after the atria have pumped blood into the ventricles. The second heart sound, dub, or S2, originates from the closing of the aortic and pulmonary valves right after the ventricles have ejected the blood. The time interval between S1 and S2 is when the ventricles contract, called systole. The interval between S2 and the next S1 is when the ventricles relax and are filled with blood, called diastole. Diastole is longer than systole, hence the lub-dub, lub-dub, lub-dub. Heart sounds are auscultated at 4 different sites on the chest wall, which correspond to the location of blood flow as it passes through the aortic, pulmonic, tricuspid, and mitral valves, respectively. This is how similar defects associated with different valves are differentiated. Heart murmurs are whooshing sounds produced by turbulent flow of blood. Murmurs are diagnosed based on the time they occur in the cardiac cycle, their changes in intensity over time, and the auscultation site where they are best heard. Examples of conditions associated with common systolic murmurs include mitral valve regurgitation, when the mitral valve does not close properly and blood surges back to the left atrium during systole. The murmur starts at S1 when the AV valves close and maintains the same intensity for the entire duration of systole. This hollow systolic murmur is best heard at the mitral region, the apex, with radiation to the left axilla. On the other side of the heart, a tricuspid valve regurgitation has similar timing and shape, but is loudest in the tricuspid area, and the sound radiates up along the left sternal border. Aortic valve stenosis. When the aortic valve does not open properly and blood is forced through a narrow opening, the blood flow starts small, rises to a maximum in mid-systole at the peak of ventricular contraction, then attenuates toward the end of systole. This results in a crescendo-decrescendo, or a diamond-shaped murmur, which starts a short moment after S1. It is often preceded by an ejection click caused by the opening of the stenotic valve. Aortic stenosis murmur is loudest in the aortic area, and the sound radiates to the carotid arteries in the neck following the direction of blood flow. Again, on the other side of the heart, a pulmonic stenosis has the same characteristics but is best heard in the pulmonic area and does not radiate to the neck. Other conditions that cause audible systolic murmurs include ventricular septal defect and mitral valve prolapse. An example of diastolic murmurs is aortic valve regurgitation. This is when the aortic valve does not close properly, resulting in blood flowing back to the left ventricle during diastole, the filling phase. As the blood flows in the reverse direction, the murmur is best heard not in the aortic area, but rather along the left sternal border. It peaks at the beginning of diastole when the pressure difference is highest, then rapidly decreases as the equilibrium is reached. Other common diastolic murmurs are associated with pulmonic regurgitation, mitral stenosis, and tricuspid stenosis. Thank you for watching.
Okay, so hopefully that let you just kind of hear some of the different heart sounds that happen when there are murmurs. Next, we need to look at cardiac output, which is the amount of blood pumped out by each side of the heart in 1 minute. And really it would be by the ventricles, since those are the discharging chambers of the heart. It's a product of heart rate and stroke volume. They both contribute to cardiac output. Stroke volume is the amount of, or the volume of blood pumped out of one ventricle each time it contracts. A couple of imbalances that can happen with cardiac output. One is congestive heart failure, or CHF. That is caused when the pumping efficiency of the heart is depressed. So circulation becomes inadequate to meet the needs of the body tissue. Usually it's a very progressive condition, so it usually doesn't happen right away. It usually builds up over time. It can reflect problems like coronary atherosclerosis, clogging or hardening of the coronary vessels, chronic high blood pressure, so years and years of untreated high blood pressure, or multiple MIs or heart attacks. The other is pulmonary edema. That is when fluid from the blood leaks from circulation into the tissue of the lungs due to the left side of the heart losing its ability to pump blood out of the heart to the body. So it kind of backs up into the lungs, and it can cause suffocation if it's not treated because of that fluid buildup in the lungs. Some things, and we're going to go into, and you'll learn how to read ECGs or EKGs. Electrocardiography is going to be done to basically look at the heart, how well it's working. So an electrocardiograph is a device that will detect electrical currents generated in the heart and transmitted through the heart that's spread throughout the body. So you would do an electrocardiogram, which is also called an ECG. It gives you a graphic recording, it makes a graph of heart activity, and it's a composite of all of the action potentials generated by the conduction system of a heart in a certain time period. And it can also be referred to as an EKG. So an EKG and ECG are kind of interchangeable terms. So an ECG would give you a graph that part of it would look something similar to this right here. It's got different waves on it, and they each mean something and tell you something different. So it would be looking at the conduction system of the heart, again, the SA node and AV node, and how well those signals are being sent. So over here we can see different things like atrial depolarization, ventricular depolarization, and repolarization. You've got different waves on here. So P, we've got the QRS complex. There's an S wave, T from the T and ST segment that we'll look at, QT interval. Each of those should be a certain range, and we'll go through how to read those. So to record an ECG or an EKG, there are electrodes, usually they're sticky, and it has a little, I would say they look kind of like snaps. It's got a metal piece on it, and the back of this would be peeled off and it would be stuck to the patient at various places, Usually there are 12 different leads that are used, and the leads essentially give a picture of the heart's electrical activity. So this just shows where some of those leads would be placed. They also put them on your arms and your legs. So a typical ECG has 3 pretty distinguishable waves or deflections, and that's going to be the P wave, that's this first part, the QRS complex, which is where it kind of spikes up and comes back down, and the T wave, which is after. The P wave shows the depolarization from the SA node through the atria. The QRS complex is going to be resulting, that would show up on our graph or our ECG, from the ventricles depolarizing. And then the T wave would show the ventricles repolarizing. The PR interval is from the beginning of atrial excitation to the beginning of ventricular excitation. So it's showing from as soon as the ventricles receive an electrical stimulation until as soon as the atria receive electrical stimulation until as soon as the ventricles receive electrical stimulation. The PQ interval is sometimes used instead of the PR interval if the Q wave is visible. Okay, it's going to depend on the person on the EKG. But it's going to mark the beginning of the ventricles receiving their signal. The ST segment is going to be when the entire ventricular muscle is depolarized. And then the QT interval is going to be the period from the beginning of ventricular depolarization through ventricular repolarization. So all these different waves essentially show different events happening in the heart electrically. Okay, so we can see what's happening essentially here. Shows you on the EKG reading what's happening. So first, to get the P wave, the atria are depolarized, and that is started by the SA node. Okay, so that will cause the P wave to appear. When the atria are fully depolarized, the impulse kind of delays at the AV node, and that gives us this segment right here. Next, the ventricles are going to be depolarized. That starts at the apex of the heart, so down here, and that causes the QRS complex, and atrial repolarization also occurs there. Next, where we have this kind of flat segment before we get the T wave, the ventricles are fully depolarized. For the T wave, the ventricles are repolarized, starting again at the apex. And then when the ventricles are repolarized, when that's finished, you get this little kind of flat line again. Okay, so all of this would show one cardiac cycle. For some issues that can be detected on an ECG or on an EKG, you can have an enlarged R wave. That can be a sign of enlarged ventricles, and that happens when like more strain is put on the heart and the heart's not working as efficiently. You could have an elevated or depressed ST segment that indicates cardiac ischemia or reduced blood flow to the heart muscle. And you could have prolonged QT, or it can be called long QT syndrome. Prolonged QT interval shows an abnormality in repolarization that will increase a person's risk of getting ventricular arrhythmias. So here we can see a normal sinus rhythm. So this person would have a normal EKG. There are, like if the SA node is not functional, we would have this. There's no P waves present. The AV node would pace the heart then instead about 40 to 60 beats per minute. A secondary heart block, the AV node will not conduct some of the SA node impulses. So the SA node is sending signals to the AV node, but the AV node isn't sending all of those signals on. So there would be more P waves than QRS complexes. So in this particular one, you can see two, like right here, we have two P waves for one QRS. Ventricular fibrillation, this is a mess. So the electrical activity of the heart is very disorganized. The action potentials occur randomly throughout the ventricles. So it's a very abnormal ECG or EKG. And this can be seen if there's like a sudden heart attack or if somebody's been like electrocuted. Okay, that can cause that kind of issue to happen. We're going to watch a couple short videos just about EKGs and stress tests.
Hello, my name is Greg Pluter, Manager of Cardiopulmonary Diagnostics and Cardiac and Pulmonary Rehab here at Allegiance Health, and today we're going to be talking about cardiac stress testing. And the indication for cardiac stress testing is to look at the physiologic effects of your heart. We want to look at the rate at which your heart is beating. We want to look at the response of the heart rate. We also want to look at the response that you have with blood pressures during the test. So we're physically looking at the heart physiologic action, or the action of the heart, and how it's working under stress. Now, the indications for the cardiac stress test are many. It can be for a cardiac evaluation for surgery. It can be for a patient who comes into our emergency department with chest pain and it's unspecified. So we have a cardiac stress test to identify whether or not there's been any type of damage to the heart. All patients who come in for cardiac stress testing, independent of the type of test that they have to have a standard 12-lead EKG electrocardiogram prep attached to them so that we can effectively monitor the rhythm of the heart. We have a number of cardiac stress tests that we perform, and a lot of it depends upon what we're looking for and the level of the patient's ability to perform a test. With our cardiac stress testing, obviously we try to get patients to perform exercise. Exercise is the best way to stimulate the heart and to get an accurate view of how the heart is responding. In many situations, the patient is not physically able to exercise, so we have to resort to using a chemical stress test, either an adenosine or a dobutamine, to simulate that activity of the heart to evaluate the function, the blood pressure, the heart rate, and the ECG changes, if any, of the cardiac stress test. We do probably anywhere from 10 to 15 cardiac stress tests a day, a variety. Today, I think we're doing some, half our tests are chemical. We have many that are walking tests, and we have 3 or 4 of the echo stress tests. So we're very versed in it. It's a very safe procedure. It's something that's very diagnostic, and it's helpful for the cardiologist and your family physician to determine what your heart is doing.
All right, and then just one more short video so you can see an EKG being done.
Hi, I'm Tanya Marsh. I'm a supervisor at Allegiance Family Medicine. Today we're going to talk about electrocardiograms, or EKG. An EKG is a simple and painless test that records the electrical activity in the heart. The doctor will use an EKG to detect any heart problems such as a heart attack, irregular heartbeats, or heart failure. With each heartbeat, an electrical signal travels from the top of the heart to the bottom of the heart, causing the heart to contract and pump blood. This signal creates the rhythm of the heartbeat. Okay, I'm going to have you have a seat right up here.
All right.
And today we're going to be doing an electrocardiogram, also known as an EKG. Have you had one of those tests before?
No.
No? Okay. So this test is going to measure the electrical activity in your heart. We'll show how fast your heart is beating, if you have a regular or an irregular pulse, and it'll show us the electrical activity in each part of your heart. There are many reasons why a patient may need an EKG. Your doctor will normally order one as part of your routine physical. If you were to complain of chest pain, an irregular heartbeat, or a fluttering in your chest, if you were to have shortness of breath, weakness, fatigue, your doctor may also order an EKG at that time. There may be also other reasons, such as a strong family history of heart disease with your mother, father, sister, or brother, your doctor may also order an EKG if you are on heart medications or have a pacemaker. So we're going to go ahead and get started on your EKG. I'm going to have you lie back, and I'm going to bring this out for your legs. All right, just relax. Are you comfortable lying like that for a few minutes?
Yes.
Okay, I'm going to have you undo your gown so I can see your chest. I'm going to place electrodes across your chest, on your arms, and on your legs. The electrodes are just small, sticky tabs that'll be placed over your body. Sometimes when men have a lot of hair on their chest, we will need to remove that hair so that the adhesive sticks better to the skin. There are about 10 to 12 electrodes on normal EKGs. I'm going to roll up your pant leg just a little bit, okay?
Yes.
Okay, just relax. Now I'm going to take these leads and hook them to the electrodes. That's what's going to create that electrical activity to show up on my EKG machine. And it'll show up on a grid on a piece of paper, or it can also show up on a screen for the doctor to read.
All right.
Okay, I need you to lie real still. Try not to move too much and try not to talk. This will just take a couple seconds. Okay, that was it. Now I'm just going to remove these leads and the electrodes. I won't be able to give you any results. You will need to follow up with your doctor, and he'll be able to go over those results with you.
All right, thank you.
Okay, so as you saw there, let me go back to where we could see that. Okay, an EKG would give you a printout like this, and we're going to be taking a look at some of those, figuring out which each of those different parts of an EKG mean. And we won't learn how to interpret EKG results, but we will learn how to read them.